Okay, can you see that?
I can, yes.
Okay, here we go. Okay, everybody. It's lovely to see you today in this midst of all this Arctic weather. I'm going to talk about challenges in screening and testing for Hep C. And I'm Judith Feinberg. I'm an infectious disease physician at WVU. And I see there's a lot of names that I don't recognize. I haven't been on Echo in a bit. So this is a kind of a basic talk. So, those of you who are old hands, uh, like Jen Boyd, don't fall asleep. Okay. So here's the issue. Uh, even though um, we've made great progress in West Virginia in getting rid of restrictions for hepatitis C. Because when I came here almost 10 years ago, um, there were just an it was just an armful of things. You had to be sober. You had to be sober for 6 months. You couldn't be a primary care provider. Blah, blah, blah. Went on and on and on. And to their great credit, West Virginia Medicaid has gotten rid of everything except the prior authorization. And I think that's primarily on their part an attempt to control costs because West Virginia is not exactly the wealthiest state. So even though we have so much better access here in West Virginia and there is much better access across the country, um, people with chronic hepatitis C are just not receiving treatment. So this is data from the CDC, high D, that shows that this is the proportion of people who started treatment within 12 months of receiving a diagnosis. And since 90% of the people in West Virginia are going to get their medication from West Virginia Medicaid, right? If this held true for West Virginia in particular, you'd see it's only 23%. Now, I don't know. This is nationwide data. And even people with private insurance, only a little over a third of them are getting medication. This is not good, right? Clearly not good. And I think there's a lot of obstacles. I bolded the ones that I think uh, are key for us here, but I'll just sort of review them briefly. People who trained before 2016 may just not even be aware that we can cure Hep C and we can do it easily and quickly with minimal to no toxicity. Because if you finished your training before 2016, then you were aware of the interferon era, and that was terrible. Interferon is a very, very difficult drug to take. The side effects were miserable, and the outcomes were not particularly good. Plus, in that era, Hep C management was completely in the hands of hepatologists and GI docs. Very early on, took a while even for ID docs to get involved in this. But there is tremendous stigma around Hep C, and this is really a problem. Kaylee, did you ask a question? Okay. This is really a problem for us in West Virginia because, of course, the primary route of acquisition is contact with infected blood, and most of that contact is through drug use. And so people who have hepatitis C are probably fairly correctly assumed to have had some exposure to drug use. And there is just tremendous confusion about interpreting hepatitis C serology. It's even worse for hepatitis B, which is in fact more complex. But there's really a lot of confusion about what a positive antibody means. And then because this is relatively new, right, in the primary care domain, people are understandably anxious and, have some concerns about diagnosing and treating a problem that's not a new problem, but it's new to them. And there's concerns, of course, from the memory of the interferon era that management may be very complex. And it's not easy to access expert guidance. Um, I think other obstacles are lack of awareness of the current federal screening guidelines, which I'll get to in another slide or so. Uh, another issue is both patients and providers are not always totally comfortable talking about the behaviors that lead to a diagnosis of hepatitis C and also actually HIV, right? And as we just mentioned, hepatitis C, of course, is so tied up with our drug epidemic. And that's a very stigmatizing problem, substance use disorder. And providers, are concerned that their patients are going to be embarrassed or angry, or that somehow their provider doesn't think well of them. If they ask about or mention screening, I know Jen Boyd, we could talk about a situation that happened to Jen a while ago, where people got really upset. And of course, in extremely busy primary care, there's not a lot of time, and there's not a lot of time to describe things to people. And in some situations, there's this sort of not in my backyard approach. For example, in emergency departments, which is, I think, a wonderful place to provide screening, because that's where people come. They say, well, we can't do it. We're too busy. It's not our mission. And what happens if we fail to follow up with the patient? What's our medical legal responsibility? So, these are all part and parcel of the problems involved in this. So here's a slide that really describes the U.S. Preventive Services Task Force recommendations in 2019 for Hep C screening. So everybody, at least once, every pregnant woman in every pregnancy, since you can clearly acquire Hep C between pregnancies, and then, of course, everyone with risk factors, which is going to be primarily injection drug use on a regular basis. What does regular basis mean? That's not so clear. I would say at least annually and maybe every 6 months. It really kind of depends on your judgment and what you know about the patient's life. So ordering the correct test is central to this. And this is the source of chronic confusion about Hep C serology. So it used to be that the typical screening test, and in many places still is, just to order a hepatitis C antibody, which you can detect like a month to 2 to 3 months after infection. And almost everyone will have formed hepatitis C antibody after exposure by 6 months. You can do this with a rapid test that gives you results in about 15 minutes, and it is positive for life, right? Even when you cure people and they have a wonderful SVR12, they're always going to have a positive antibody. And the problem with just using the Hep C antibody as your diagnostic tool is that without a confirmatory nucleic acid test, or you sometimes see that abbreviated NAT, this is a worthless test for medical decision making. In fact, I've had conversations with both Quest and LabCorp to ask them if they would just remove this test from their list of offerings, because as a clinician, there's nothing you can do about a positive Hep C antibody except call the patient back for a confirmatory test. So you might as well just get the whole thing in one fell swoop. And the confirmatory tests, of course, detect the fact that the virus is actively replicating. And the most commonly used methodology is PCR, polymerase chain reaction. There are qualitative sort of yes/no tests, but really the test you want is the viral load, is the quantitative test, because that will tell you how much Hep C there is in the patient's blood. And you can see this as early as a couple of weeks after infection. So the test to order is hepatitis C antibody with reflex to RNA PCR. And that means the lab gets one tube of blood. If the antibody is positive, they just automatically go ahead and look for the presence of the virus. And that way you don't have to bring the patient back in, which, as we all know, since transportation is another obstacle to care in West Virginia, you don't have to bring the patient back in. And you get an answer with 1 point. And then actually there is the FDA a few months ago approved a point of care test that will confirm the diagnosis using RNA detection in about an hour. Cepheid is the manufacturer, and it uses the same platform that Cepheid, the same physical machines, kind of looks like the size of a printer, that, Cepheid has been using that platform for many diagnostic tests. But you need to buy the reagents and the software for specific for hepatitis C. And I think the problem is it's not going to be as financially accessible in many settings. And when you try to find out what they want to charge for it, it's a big rigmarole. Are you a government? Are you not a government? Are you profit? Are you not for profit? I cannot figure out, let me just tell you that. I cannot figure out what it costs to buy it. And then the last thing in terms of testing is that has been important over time is determining the genotype, of which there are 6, and some have A and B subtypes. And this is useful information along with the quantitative PCR for thinking about the choice and duration of therapy. Genotype 1 is the most common in the United States and is the most common in West Virginia. But West Virginia is unique in that we have a huge amount of genotype 3. This is most unusual and sad for us because currently genotype 3 is associated with a more rapid rate of disease progression. And you can see it's about 20-25% of our hep C is geno 3. But West Virginia Medicaid, which remember covers 90% of our patients, their 2 preferred regimens are both pangenotypic. So you really don't need, in West Virginia, you really don't need to get a genotype unless your patient's insurance requires it. Medicaid has long believed that this would be useful to help distinguish reinfection from treatment failure. But think about it, if the genotype doesn't change, that doesn't help you at all. And since the most common genotype is 1, you could have a geno 1, you could be cured, you could relapse to drug use or continue drug use and reacquire genotype 1, and you will not be able to figure out whether this is true reinfection or relapse or failure to respond. So frankly, I don't think it's very helpful, and I've been trying to talk Medicaid out of requiring it because it's quite an expensive test. I think that's the end of my slides. So let me stop there and happy to take your questions.